Return to the ASC has been made possible with support from Johnson & Johnson Vision. We'd like to thank our sponsor for their support of this programming. Ambulatory surgical centers have been forced to adapt during the COVID-19 pandemic. In this program, we'll hear from Regina Boore, Senior Vice President of Progressive Surgical Solutions, Albert Castillo, CEO of San Antonio Eye Center, and Todd Albertz, Vice President of Surgical and Specialty Services at Cincinnati Eye, on the ever-changing safety guidelines, staff considerations, product uses, and more. And now, here's our host.
I'm CEO of Loden Vision Center, President of Loden Vision Center, and we want to really thank J&J Vision for sponsoring us tonight on this, but we've got a great faculty here, and I'm going to really turn the conversation over to them. I'm a managing partner of an ASC, but Albert's manager of one ASC is in the process of opening a second 22-doctor practice. Regina has operated her consulting business on ASCs in the United States, Canada, Puerto Rico. Todd is with CVP, and he has 99 surgeons and I think 22 ASCs. So we've got a great experienced crowd here. So Regina, we're going to start with you tonight, and we're going to talk about ever-changing guidelines. With your nursing background, you're really experienced in these guidelines. So kind of take it away right now and help us through the new guidelines in this post-COVID-19 reopening.
Sure. Well, I think most of the changes now, there was a time in April where it seemed like it wasn't just weekly or daily, but it was practically hourly that we were having to, research and dive into more and different guidelines. I think that most of the dust is settled at the CDC level and at the CMS level. There still are a lot of changes, I think, at the state level, because it really just depends on the state that you're operating in and where the state is as a whole in terms of what they're allowing and how whether they're requiring mandatory testing for admission to an ASC or if they're, depending on how locked down they are as a state. So you still have to obviously really constantly refer to your state and local authorities for the latest and the greatest. I think the one thing that we're seeing at a overall federal level is that CMS has instituted focused COVID surveys. We've been getting feedback from many clients that they have been they've experienced these new surveys. The surveyors are using a new guideline. It's actually COVID-focused infection control surveys for acute and continuing care. They acknowledge that not all of it is going to apply to ASCs, but certainly the portion that does apply to ASCs, they're using this tool. There's obviously a big focus on hand hygiene, on personal protective equipment, a big focus. They interview staff. They definitely do a case tracer following a patient through the entire admission to discharge process. And they're very focused on policies and procedures that you've developed post-COVID, all about screening your staff, screening your patients, screening everyone who enters the facility, obviously universal masking, spatial distancing. If you're doing any aerosol generating procedures, there's a big focus on the way that you're managing those potential exposures and the use of the N95 masks. And I think one of the big takeaways from all the people that we've talked to that have been through them is documentation is going to save the day as usual. So not only having these policies and procedures, the checklists, and implementing everything consistently, but making sure that you've got the meeting minutes and the documentation to show that from a governing body and a governance perspective, that your governing body has been engaged and is providing oversight and approval on all of these changes.
I think the most important thing to do is reach out to your local health department. For us, that was a lifesaver. In the beginning, before we even started, as they developed their protocols, we said we're going to implement Metro Health, which is City of San Antonio, the Texas Medical Board, and the CDC. So we took all three protocols and we came up with one plan. And it's been good for us in the sense that it's given us a sound set of guidelines that, if one supersedes the other, you go to the next. And we deal with every situation from that perspective. And it really makes it easy to manage your employees, your staff, your patients. When they come in and they don't want to wear masks, because we still have that to this day, we're pretty easy to say, Texas Medical Board says that as a physician, we have to wear masks. Can you please do that for us? Because that's what they require us to do.
One of the things I found is people love pearls that they can implement. That was one I'm thinking about implementing already. Regina, give our viewers some pearls that they can actually take home and implement possibly tomorrow even.
Well, we work primarily with physician-owned and independent surgery centers. So a lot of our surgery centers are 1 or 2 OR centers. And one of the things that we've found has been very helpful is implementing some form of patient engagement software that these centers hadn't previously invested in. And, it's really streamlined the preoperative and assisted. It's really enhanced and facilitated the pre-op screening process and allowed us to have better and more consistent documentation pre-arrival and obviously cut down on the amount of time that we're having to spend vis-a-vis with the patient after they get to the facility.
Well, I would share with you that, in my perspective, in working in our practice or clinic and with the social distancing as well as in our surgery center, that what we've actually found and realized is that we're more efficient with some of the protocols in place. And so in limiting how many family members can come in, who can assist, when they assist, we're able to notify and see visually, how many people do we have in the waiting room? How many people need to go to the back? How many people are ready for surgery? In our perspective, we've actually considered that after the pandemic, post-pandemic, that when we go back to full speed, we remain where we are right now and we keep the same protocols, not having 5 family members and 2 grandchildren with them. So it's been a lot of efficiency for us.
A lot of practices comment to me that this same similar experience, that they feel like they're given a better customer service experience without 3 hanger-oners being there all the time. Todd, what have y'all noticed at CVP?
Yeah, at our regional facility where we have 7 ORs, we've experienced the same thing. I mean, our waiting room is not right sized to be able to social distance. So what we did was we made the decision that both Regina and Albert have made, and that is that our family members, once they come in and sign their companion policy, they go back out to their car. We created an area kind of close to our post-op discharge area that we've sort of fenced in and set it off from the rest of the staff parking area. And I've hired an attendant to work out there. They check the family member in when they come back there. They have coffee and tea and water, and they go around and check on everybody in their car. We bought a bunch of Adirondack chairs and just kind of threw them out in a shady area where people can kind of get out of their cars and go to that area. So it's created a different experience than what we've been used to. But you guys are absolutely right. You're spot on. It really changes the internal workflow of the surgery center when you're taking those 5 family members out of the building and moving them into somewhere else.
Yeah, one of the things we implemented is buying compounded dilation drops. You can get them from OSRX and Imprimis. That's one of our pearls where we're selling them with like a compounded antibiotic steroid combination drop. With our standard cataracts, we're giving it away for free with our laser upgrade cataracts. And the patients arrive fully dilated. They're asked to put a drop in 30 minutes before leaving their house and one right before leaving their house. And it dramatically decreases the nursing touches and improves the flow because we don't have people waiting for the femtosecond laser for them because they're slow dilators. So that's been a great throughput for us. The limited family has really helped us out. Having nasal cannulas on everybody instead of the oxygen tube, obviously due to sterility issues, but the flow of oxygen, being able to keep the patients masked all the time with that. Just a couple of the pearls that we've done that have worked well in our surgery centers as well. Let's move on. Staff members testing positive. Who wants to take that one on? How to handle that? How long to quarantine them? How many tests to do? All of that sort of good stuff.
Dr. Loden, I can jump in on that.
Take it away, Albert.
All right. Well, I think that's probably the most critical and key component of any clinic and surgery center is that making sure you have a sound policy. The biggest thing that we did was go back to Metro Health, and we went to the Metro Health guidelines. And so they'll tell us that if you have a case, and in the beginning, what we did on every case is we called Metro Health and said, we got this situation, what do you want us to do? And afterwards, we've kind of figured out that there's a pretty, set policy as to how Metro Health will consider somebody COVID positive and if you're high risk. If you're considered medium risk or low risk, Metro Health Department and the contact tracers don't even reach out. It's only the high risk cases where you're out and exposed and nobody has a mask on. And so what we do is if you don't have symptoms, you come to work, you don't have fever, then you're fine to come back to work. If you're a tertiary, experience, because we have had family members, well, my sister's daughter, tested positive and they came over to the house and how do we handle that? And so it's kind of tertiary to our employee if they weren't really exposed and they live with that person. So we say, let's monitor your symptoms. And if you have something that comes up or you feel that you need to get tested, then let's get tested. But what we've also done is we said it's not up to us as the owners of the practice. It's not up to the managers. It's up to you as the individual to decide when you need to be tested and if you need to talk to your doctor. I think that is critical because it protects you as an employer to say that you're not saying you got to go get tested before you come back to work. If you force somebody to get tested, you can come into a lot of legal liability in the sense that you're trying to be their doctor. And as the administrator or CEO or manager, you're not really a doctor. The other thing that we've done is when it comes to holidays is we've educated people, our employees primarily, and for them to educate their families is that, we know you want to spend time with your family, your, sisters and brothers and uncles and cousins and grandparents, parents, but let's also be safe. And so every holiday, the Friday before, we send out an email saying, here's where we are, guys, with, COVID positive tests in our company. There's not very many, but let's be smart and let's make sure that we social distance, we keep our masks on, we do what we're supposed to and be right.
So Todd, you're big enough in your company that you have an entire manager dedicated to this for CVP, correct?
So, we've used our infection control department to kind of help navigate a lot of the decisions that we make. We also have a compliance officer for all of CVP that's been, sort of on the front lines of this, not just looking at it from the surgery center standpoint, but the clinic and administration standpoint as well. Yes.
Regina, what have you seen nationwide? You're in multiple states, multiple countries.
Well,
do you see any variation in that, or is everybody pretty much doing it right, doing it the same way with the employees, or is there a lot of leeway?
No, and I think that's a really sound approach, Albert, for those kind of potential at home, extended family exposures. I mean, I assume if you have someone that shows up at work and develops a fever, you send them home immediately, and those people you're testing before they come back, right? If they develop symptoms.
Yeah, so if they develop symptoms, it's actually afebrile for 72 hours. And if they decide to go get tested by their doctor, it's 14 days from the time they're tested. That's our policy. Even though CDC says 10 days, we're 14 days.
Okay.
So
but you don't mandate if they become symptomatic that they get tested. You basically still leave that up to them too.
We do.
And so if they go out with symptoms and their symptoms resolve and they're like, I'm good, I'm coming back to work, you're cool with that? 72
hours afebrile.
Okay.
And so if you think about what's out recently, it says that the first symptom of COVID is fever.
Right.
I think the biggest thing is just everybody in the office wearing the mask, right? If everybody's keeping their mask on all the time, transmission rate really remarkably goes down. That's something we've tried to just really pound. I know we're close to our halfway mark right now, and again, I'd like to thank Johnson & Johnson Vision for sponsoring us tonight. Without industry support, so much of what we do can't go on, so we want to really thank them for this time tonight on sponsoring Return to the ASC. The first topic on our part 2 is utilization of products like Omidria, Dexecue to optimize outcomes, compounding, anything to prevent complications, reduce pharmacy visits. I know there's a whole lot of different perspectives on this. So Todd, you've got the most doctors. Tell us a little bit about different products that are being used with CVP and how you integrate that with so many different perspectives.
Yeah, thank you. So, one of the things that we're working on, we're continuing to sort of work through the testing and develop guidelines for is we have our own internal compounding pharmacy. So we've been, working with our pharmacists and that group to develop a post-op slurry that we can dispense and use for post-op medications to try to reduce the amount of post-op drops that patients have to deal with and work through for cataract surgery. So that's something that we actually started before the pandemic, and we expect to be able to have that available for our cataract patients probably within the next 3 to 4 weeks, and we think that'll be a real benefit.
Albert, what do you see with your docs?
Yeah, so I think it's a little bit different on our perspective. We've looked at the droperettes to dilate our patients and to help with efficiency. But for the most part, we're pretty, I guess, conservative when it comes to executing new medications or pharmaceuticals at this point in time. And the primary reason for that is that we're just back to work. And so if you look at the OOS numbers, you got about 100% of ASCs are open at this time. 85% of those ASCs expect to be above or beyond where they should be for the year by 12/31. And you have 45% of those facilities who've already exceeded those benchmarks and they're doing better than they were pre-COVID. We don't want to make things any more complicated than they already are because we don't know where it's going to go. So our perspective is Omidria, Dexecue, we already use combo drops. These things are all going to be beneficial to patients, but we don't want to make our process any more complicated at the time. Let's go ahead and continue to do what works. Let's be, successful and efficient and take care of our patients. And when the time comes, we can look at Omidria and Dexecue and all these other items that are available or products that are available that can help, make the post-operative recovery even better. It's just a little bit more conservative from our perspective that, it's not worth the risk given its uncertain times.
Regina, what are you seeing across the country?
I think our clients more fall into that camp. I think really just more from the perspective of, integrating and assimilating all the change that's come our way in the last 3 months or 4 months, excuse me, has taken a lot of energy and a lot of focus and a lot of time. And everyone is still, I think at this point, most of our clients are still focused on just trying to reestablish normalcy per the sort of pre-COVID experience. Not that it necessarily has to look exactly like that, but just that we sort of get to that comfort level and to that level of efficiency in our operation. And then I think once people get comfortable at that new normal, then we can sort of adjust our sights and start looking at other opportunities, other ways that we can improve our operation and improve our efficiency and improve the patient experience and, consider new technology and new pharmaceuticals. I mean, I would say that more than not, that's sort of where I see most of our clients.
I'm kind of at a point personally where I just want to hit a whole lot of bunts and base hits and walk on base, It's not a time where I really feel like I want to be an innovator, which is my personality, is to want to go out and try new things. I really am kind of with you, the consensus here, that I think it's a tough time to sit there and try new things, and that maybe something the industry wants to think about when rolling out new products. It may just not be the time. All of us want to just sit there and hit a whole bunch of base hits all day long, every day. And
right. We just want to get through the year, right?
Yeah, we're just getting through the year. And I think all of us are worried about, are we going to be allowed by our city or state governments to get through the year, right?
Right.
I mean, what happens? That's the big unknown. So I think all of us are like, it's like me. I added cataract surgery on Friday. We were booked out a couple of weeks. We said, hey, man, we need to add some cataracts here. We got a day. I'm not in LASIK this Friday. Let's put another 14 cataracts on Friday morning. Just get them knocked out while we can. We don't want to book out right now, right? You just want to get as much done as fast as you can get done and build some revenue in these facilities and build up cash flow and build up your cash reserves in case something happens again. I think all of us are in that same boat here.
I don't think any of us feel like this is behind us. You know, I think there's still a sense that we're smack dab in the middle of it.
So do you see anybody thinking about simultaneous bilateral surgery to reduce touches? What are y'all's thoughts on bilateral surgery at this juncture?
So in my perspective, if you have the right patient, yeah, that might work. But if you have the patients that are, 250 pounds, diabetic, high blood pressure, and, they want both eyes done and they're dense cataracts, you probably don't want to do that, because if you have one eye go bad, it's not going to be fun.
Todd, I know some of your surgeons personally very closely, and what are y'all's thoughts?
Well, I think it's something that, would be really interesting to explore down the road. At this point, back to, what we were talking about earlier with different medications and things like that, we're just trying to survive and get through the year. So we're really not looking to do any advancements like that.
I think a lot of people have gone to the virtual one-day post-op too, to reduce number of touches, number of travels. And in the practices, one of my practices does that. We do a one-day phone call, obviously with people getting MIGS procedures or transplants or anything complicated, superficial keratectomies at the time of cataract surgery. We bring them back in for the day one, but just a routine standard cataract surgery, simple phone call, telehealth visit in our rural communities does great.
Albert, you all did a lot with telehealth that you're going to continue to do too, right?
We have. It wasn't necessarily a lot, but what we've actually used it for is we have a report that comes out every Monday, and it's the COVID cancellations. And so we use the telehealth to reach out to those patients to review their chart, talk to the patient, and also bring them back in. We have a lot of really sick patients, demographics of San Antonio. That's kind of what we have to deal with. So we used it as an opportunity for those patients who were too scared to come back to the office to actually talk to them, consult with them, and then also make a determination and educate the patient if they really had to come back and we needed to see them, whether it be for an injection or a surgery or something else. We would use that opportunity to say, well, you had this scheduled and we kind of moved you off the schedule, but it really is important for your eye health that you do come back. So we use it as an educational purpose, but it wasn't necessarily to generate more revenue or to make up revenue. Our clinics were already busy. We were like 110% with no-shows on our first day. It was absolutely absurd as to how many patients wanted to come back to our office. And there was no fear in coming back to the office, and we still kind of experience that. Our no-show rates are relatively low.
Albert, to your point, about ramping back up, one of the things that we ran into when we were opening back up and ramping back up was that the primary care providers weren't back in the offices yet. So we had patients that we were struggling to get histories and physicals on. So that was a real opportunity for us to expand our history and physical clinic and hire an additional nurse practitioner to allow us to get through that pipeline of histories and physicals. We had over 1,600 cases that were canceled during that March to May timeframe, and so getting them back on the schedule, as well as taking care of patients that were coming in new and looking to get on the schedule, really was a challenge for us. So that nurse practitioner role was vital in allowing us to ramp back up.
We're
Dr.
down.
Loden, you're still doing a lot of LASIK too, right?
Our LASIK practice is doing extremely well. For numbers perspective, last August, I've had my August numbers, but July of last year, we were only about 88 eyes of paying LASIK. We hit over 170 eyes. And the interesting thing is we did that with all digital and no radio, no TV marketing. So that may be a new frontier, that you can do the same volume without a lot of external marketing if you're very well placed digitally with your online reviews and you have your SEO and SEM optimized very well. It's been a revelation to us that we could grow our LASIK business without this external marketing. We cut our radio, we cut our TV, and we cut our billboards off, and we saw our business grow. So it's very interesting phenomenon, but great for the pocketbook. Is I think Albert, CEO of a practice, would be like, wow, this is great stuff, right?
Yeah, it's fabulous.
We're down to about 10 minutes left. If anybody has any questions right now, please send them in to us, and we'll try to hit on a few more questions here as we wind up today. Regina, any more pearls for us? Just kind of a wrap up here for us?
Oh, I think the biggest one is just the communication with the staff. I think, I had conversations with Albert very early on, and that was one of the things that they made their decision to shut down suddenly and completely. And he shared a lot with me about how they approached it in terms of internal communications with all their providers and the employees. And with so much of what could be just sort of, monumental upheaval and sort of, just so much change that everyone's going through, not just in the workplace, but personally too. I think that you can't over communicate with your staff through this whole thing. I think that's been one of the most critical factors for being able to be successful.
Regina, I couldn't agree more. During the entire shutdown, every 2 weeks, we had a town hall Zoom call for each one of our facilities where we gave an update on what was going on. We talked about, answered any unemployment questions or, talked about those kinds of things. We just listened, and we gave the staff an opportunity every 2 weeks through the pandemic to, have an ear and have an opportunity to voice concerns and talk about things, and we've got a lot of positive feedback afterwards about how much staff valued that opportunity.
Yeah, I bet.
Well, I want to thank everybody. We're down to our 1 minute mark here, so I don't want to be a preacher and going too late. That makes everybody unhappy. So we're going to wind it up. I want to again thank J&J Vision, thank Regina, Todd, Albert, Elizabeth, Jared, everybody that helped put this on, and folks at Burnmall Communication. It's a great time, everybody. Y'all did such a great job and helped us out through this reopening of our ASCs, and look forward to getting back together with some meetings sometime, hopefully in the future. Thank y'all so much.
Thank you, Dr. Loden.
Return to the ASC has been made possible with support from Johnson & Johnson Vision. We'd like to thank our sponsor for their support of this programming.